The third lecture is how to set up transplant clinics, various transplant clinics. And the idea is to give you how this clinic should be run so you can take the idea to set it up in your own renal units. The three main objectives is how to set up a live donor clinic, how to set up a recipient assessment clinic, and how to set up a transplant follow-up clinic. The live donor clinic should run in multidisciplinary approach. The main aim of the clinic to assess potential live donors. Donors who are placed on the pair pool should have annual review to make sure that they're fit to stay in the pair pool. The live donor clinic should assess the patient preoperatively and have the final preoperative check and final cross match. After donations, the donor should be followed for life annually in the live donor clinic. Having the live donor clinic in a multidisciplinary team approach with the potential donor in the center, it should include a renal physician for medical assessment, transplant surgeon for surgical assessment, the live donor transplant coordinator, as we've discussed, its essential role for fast tracking, filtering and triaging of unsuitable donors. And some live donor clinic might have renal psychiatrists, which would help assessing potential donors and altruistic donors. There should be the option of fast tracking where all the investigation and assessment should be quick and fast within a week or 2 weeks, especially for recipient with rapid decline in the kidney function, aiming for preemptive transplantation if possible. In summary, the live donor clinic, where the donor will meet first the live donor coordinator, identifying potential incompatibility issues, whether HLA or ABO or POS, tissue typing, cross-matching, then medical assessment, surgical assessment, multidisciplinary team discussion for difficult cases, independent assessment, donor nephrectomy surgery, and long-term follow-up. We have discussed the role of the live donor coordinator in previous lecture, in particular screening, blood group and tissue typing, screening of donors through doing the blood group and tissue typing, identifying the primary contraindication from history and drug history, routine blood and urine analysis test, and initiate early triage of unsuitable donor, giving consent, giving oral information, written information, and taking consent. After nephrectomy, the donor should be followed up, initially 6 weeks post-donation, and then after that annually, where we look at the kidney function, the blood pressure, proteinuria, hematuria, medication, new comorbidities, risk factor for CKD and cardiovascular disease. The recipient assessment clinic. Some call it the Transplantation Assessment Clinic, and again that's in multidisciplinary team approach with the potential recipient in the center, having a renal physician for medical assessment, transplant surgeon for surgical assessment. Some might have a dental or vascular or access to dental and vascular through the clinic. Some clinics have a cardiologist sitting in for assessment because most of these patients will have high cardiovascular risk, and significant percentage of these patients will get referred to cardiologist. There is a transplant recipient coordinator as well, with the aim of facilitating the pathway for the potential recipient. The role of the recipient coordinator is mainly blood group and tissue typing, sending blood group and tissue typing, routine blood and virology, written and oral information, taking verbal and written consent from the potential recipient, identifying social and ethical issues, identifying live donors, assess the CKD status and trying to push for preemptive transplantation if possible by fast tracking, chasing up the results in the scans, and suspension of patients on the transplant list when they are unwell or if they got admitted to the hospital. We have discussed the importance of annual review for patients on the transplant list, and that should also occur within the transplant assessment recipient assessment clinic. The transplant follow-up clinic after receiving a kidney again should be a multidisciplinary approach with sorry, that's not the potential donor. This is an error. It should be the kidney recipient after receiving the kidney, where there is a renal consultant, dermatologist for skin review, transplant nurse for post-transplant issues, social worker and pharmacist sorting the medication, the immunosuppressive medication. During the transplant follow-up clinic, there is a routine transplant review, taking blood pressure, weight, urine dipstick for proteinuria and hematuria, and asymptomatic bacteriuria, sending MSU, urine ACR and PCR, identifying new proteinuria, full blood count and kidney function, medication review and prescription, bone profile, parathyroid hormone, and the levels of the immunosuppression, sirolimus levels and calcineurin inhibitors levels, assessing the cardiovascular risk and complications of the immunosuppressive medication, identifying new onset diabetes after transplantation. Other medical or surgical post-transplant complications or complication of the medication should be also assessed and reviewed. If there is rather than creatinine, there will be a review of symptoms, recheck of the kidney function, searching for obvious causes, infection, UTI, dehydration, antibiotics, or any other medications. And the investigation to be considered is renal ultrasound, CRPN cultures, virology, particularly CMV and BK virus, CNI levels is too low or too high, and finally renal biopsy to ascertain the cause of the rising creatinine after excluding all the obvious causes. It is essential part of the clinic and essential role is to monitor immunosuppressive drugs. Whenever there is a change in medication or the patient's status that might affect blood levels, whenever there is medication given to the patient that could interact with the immunosuppressive medication, whenever there is declining kidney function that may indicate nephrotoxicity or rejection, monitoring cyclosporin using the 12-hour trough level or C0, 2 hours post-dose C2, monitoring tacrolimus using the 12-hour trough levels. Some center might monitor the cell sept or myfortic levels, and the mTOR levels should be monitored as well. Transplant patient should have annual review where the creatinine and immunosuppressive levels trends should be looked at, immunosuppressive regimes and side effects and complication, cardiovascular risk, diabetes and hyperlipidemia should be assessed, recurrent UTI, skin lesions and skin review, screening as per general population for cervical, breast, colon, prostate cancer, not more than the general routine screening for general population, assessing lifestyle, pregnancy, and if there was any rejection episode during the year. Thank you.